your feedback. If you are hoping to get a completion certificate for renewal hours, please be sure to indicate right in the survey how you would like your name to appear on the certificate. So I'm going to start us off and we'll be providing a brief legislative history about the Child Abuse Prevention and Treatment Act, CAPTA, which was first enacted in 1974. So in order for states to receive CAPTA funds, they're actually required to ensure that they operate programs relating to child abuse and neglect. And over the past 47 years, some updates to CAPTA have been made by changing and clarifying language and also stipulating new conditions and requirements for program improvements. And of most significance for today's topic are changes that were enacted in 2003, known as Keeping the Children and Families Safe Act. And also in 2010, the CAPTA Reauthorization Act that specifically provided clarification on the definition of substance-exposed infants and also added fetal alcohol spectrum disorders to it. In 2016, CAPTA was then further amended by the Comprehensive Addiction and Recovery Act, specifically Section 503, which addresses the requirements for development of plans of safe care and further clarifies the population requiring the plans of safe care as born with and identified as being affected by substance abuse or withdrawal symptoms resulting from prenatal drug exposure or a fetal spectrum disorder. With the most recent changes also come federal and state requirements for data submission to the National Child Abuse and Neglect Data System, which is a voluntary data collection system that gathers information from all 50 states, the District of Columbia and Puerto Rico about reports of child abuse and neglect. So here in New York State, we are collecting, specific now to today's topic, the number of infants identified as being affected by substance abuse, withdrawal symptoms resulting from prenatal drug exposure or fetal alcohol spectrum disorder, the number of infants for whom a plan of safe care was developed, and the number of infants for whom referrals were made for appropriate services, including services for the affected family or caregiver. So who has responsibility for development of the plan of safe care? Here in New York State, the Child Protective Services Manual addresses positive toxicology of newborns and creating a plan of safe care. And as you can see here on this slide, there's chapter 6 in this manual that specifically addresses that piece here in New York State. And the Office of Children and Family Services has put together a decision tree to ultimately help determine when hospital staff has to complete a notification for the birth of a substance-exposed infant versus making a report to the central register. As most of you probably are aware, hospitals always had a responsibility to make a report when there was knowledge of maternal substance use. But what is different now is that only when there is a child protection concern or a child safety concern, a report to the state register is required. So when we look at this decision tree, again, any child protection concerns would require what we've always done, in essence, making a report to the statewide central register. But when there aren't any child protection concerns and any of these following conditions are true, then the report to the central register is not required. And so those areas that we are talking about are ultimately moms who are in treatment for a substance use disorder and are being prescribed or administered an addiction medicine by a healthcare provider. So that could be methadone or buprenorphine. Then mom is under the care and treatment of a healthcare provider for chronic pain and is taking opioids as prescribed. Or mom is taking benzodiazepines also prescribed by a healthcare provider and she's taking it as prescribed. Or lastly, mom is taking medical marijuana as directed by a registered practitioner. Or a newborn has withdrawal symptoms or is diagnosed with neonatal abstinence syndrome due to the intrauterine exposure to a prescription medication regimen being taken as directed by a healthcare provider. So in those cases, the hospital ultimately has to send in a notification to OCFS, and I can show you what that actually looks like. So this is ultimately, again, you kind of see the what you previously saw on the right side of the slide is like on this form now, where basically the hospital ultimately checks off which condition is true. So let's say it's a mom who is in a methadone program, then we would be checking off here that the mother is engaged in addiction treatment and is taking medication as prescribed or administered by a healthcare provider as part of an MAT program. And then in the section below, the hospital social worker would also indicate if a plan of safe care was completed. And, you know, there will also be information included, you know, what the name of the addiction treatment program is, or maybe if mom was in a residential program before she came to deliver the baby, will she be returning there? So this information is collected. And then at the very bottom, ultimately, there is no patient identifying information. So that's really important here. So it's not like the hospital is sending the name of the mom to OCFS. What they are saying is, here at Crouse Hospital, we had a birth of an infant that is substance exposed. And each hospital, including our hospital, has a unique hospital identifying number that is indicated here. And then we basically list the phone number and a hospital fax number. So this is the form and this is the notification, the CAPTA notification that is completed. So what is a plan of safe care? Well, it is something that is designed to ensure the safety and well-being of an infant with prenatal substance exposure. It addresses the immediate safety, health, and developmental needs of the affected infant. It also addresses health, mental health, substance use disorder treatment needs of the affected parents or caregivers, any kind of family or parenting support that might be needed, referrals to appropriate services and resources. And what's really important is it is developed with the input from the parents and caregivers in collaboration with the healthcare provider and any other professionals and agencies that are involved in services of the affected infant and family. Here are some best practices when it comes to plan of safe care. So ideally, it is developed prior to birth. It's meant to be a comprehensive multidisciplinary assessment. Again, there are multiple intervention points when it comes to plan of safe care. So during pregnancy, then also at birth, and then definitely beyond that as well. As already pointed out, it does address needs of the infant as well as the family and caregiver. And it provides a nice structure, you know, to ensure coordination of and access to an engagement in services. It's really kind of a nice little roadmap for the moms, for the pregnant mom. So OCFS actually developed a plan of safe care document that can be accessed right on their website, and it is available in multiple languages. And one of the things that, you know, we have been using this in our treatment facility with women who might be on methadone or buprenorphine. And the feedback that we had gotten is that the fact that right on top it says New York State Office of Children and Family Services is creating a lot of anxiety in our pregnant moms. And especially when we develop this here prenatally and really want to use it as a tool to provide mom with resources and support, we found that that is almost like a turnoff, and mom gets really suspicious and ultimately is wondering and concerned about, you know, is CPS going to be in my life? So I did reach out to OCFS and asked if, for the purpose of developing this basically as part of our treatment program here as an addiction treatment program, can we ultimately make some changes to this? And what we were told is we can definitely make it our version. So we did develop what I call our Crouseified version. And let's see, I have an image of that for you. Oops. So what we did is we took all the elements of the form that OCFS developed. So it's all still covered on this form. But what our plan just says on top now is basically a prenatal plan of safe care. And we do look at the family strengths and what are their goals. We also look at what kind of supports they already have in place. We take a look at what kind of protective factors there are, kind of make a list of all the services mom might already have in place, and then take a look at, well, what additional services does mom need as she gets closer to the birthing event, but also certainly beyond the birthing event and bringing the baby home. And with the feedback of some of our counseling staff who have used this form, we then added a section on here that's called Educational Topics Reviewed. And so these are some of the topics that we found are really helpful, especially for moms who are on an MAT, to review prior to the birth event. So there are neonatal abstinence syndrome, postpartum depression, shaken baby syndrome, parenting classes, breastfeeding. We're also providing mom with like a newborn essentials checklist, a hospital bag checklist, family planning is another topic, and pediatric care. And then basically, like I've already pointed out, this is meant to be a document that is developed in collaboration with mom. So mom really has a lot of input in this. And then if there are other service providers involved, we might also want to work with them on that. Ideally, the plan of safe care is something that mom would then bring with her to the hospital. Now, we all know how that is not always logistically possible, and might be the last thing mom thinks about as she's getting ready for the hospital. So what we have instructed our counseling team to do is also obtain a consent for release of information for the OB provider as well as the birthing hospital. So in that way, we as an addiction treatment provider can share this plan of safe care in advance, and it's already something that's available to the OB provider as well as the hospital. And I think it then helps with really making sure that mom has a positive experience. So, we want to, of course, not get mom involved with CPS. And, if you have a mom who's stable in her treatment, then, there really shouldn't be a reason that CPS gets involved because she's following all of the recommendations of treatment. The other thing is, so back in 2016, OASIS, which is our oversight agency, secured some in-depth technical assistance from Children and Family Futures focused on implementing plans of safe care here in New York State. And back then, Onondaga County, as well as Warren County, were pilot counties that participated in rolling out plans of safe care in their community. So here in Onondaga County, we've done a lot of work in implementing it, and there's still a lot of more work to do. But one of the, I guess, accomplishments from our work back in 2016 was development of a brochure that ultimately explains what the plan of safe care is. So this is something we brought multiple stakeholders from our community at the table. And with everyone's input, we came up with this brochure that ultimately can be given to a pregnant mom to explain what the plan of safe care is. And, we included some local resources on this as well, and, left a space on there where basically organizations can put their information on there as well. And that's something we're more than happy to share. And if, I'm not sure, I think we have an audience that is from different parts of New York State. So if anyone is looking to adopt this for their area, we're more than happy to share this document with you. As I've already pointed out, this really is a cross-system collaborative approach. And, these are just some of the organizations and partners that might be at the table. I'm sure the list is much longer than that, but just to, again, give you this idea of, this is not something you kind of sit down with mom alone. You really want to make sure that you are inclusive of all the different systems that mom might be involved with. And lastly, in conclusion of my part of the presentation, what I'd like to point out for those of you who are OASIS certified addiction treatment providers, OASIS actually published a local service bulletin back in 2019 about plans of safe care. And I think what's really important here to note is that OASIS certified providers who are working with a woman who is pregnant or becomes pregnant while in treatment will be required to ensure that she has a plan of safe care prior to the birth event. So this is really something, you know, if you are working in an addiction treatment center, you really want to make sure that you assist mom in the development of this. And again, it's really, like I said, a great roadmap to help mom as she prepares for the birth event. And with that, I'm concluding my part of the presentation.
Thank you so much, Monica. Now we have a quick, it's a 10-minute video showing you how a plan of safe care actually happens. And it's really awesome. So I hope everyone enjoys it.
Hi, Danielle.
Hello.
Thank you for meeting with me today and being willing to videotape this for our purposes of plan of safe care training. So by way of review, I just want to kind of go over what we've already gone over just to make sure that you understand what we're doing and why we're doing it. So the plan of safe care that we've already met a couple times. We've been kind of coming up with this plan. It's that written list of resources that can help support you now while you're pregnant, and then also after you give birth to the baby. It's kind of a written plan that we have everybody who's involved in your healthcare here in outpatient treatment, the hospital, the OB office, everybody is communicating with one another. So it works together like a safety net. That way we're helping to support you for anything that you might need. It's kind of like a provider support network. So we're not all referring you to the same place. We just have one place that we're referring you by one person. So we just kind of work together to make sure that you and the baby have everything that you need. So we had already kind of started some of the process. So I'm going to share my screen with you so we can look at this together. Can you see that okay?
It hasn't came up yet. Okay, yes, I can see it.
Okay.
Now, will I get a copy of this too?
Yep, you'll get a copy, and the copy will go right into your bag that you'll take with you to the hospital.
Yes,
And
okay,
then we'll make sure that the doctor's office has one, and also the hospital will have one before you.
Okay.
Yeah, that's a good question.
So I've also, me and you have been talking about the fact that since I am having a baby on methadone, you know, CPS will have a conversation with me. Is that one of those copies go to her as well, or him, the CPS worker that's going to be there?
So that's part of this process that is really important, Danielle, is that because you are on methadone and in treatment, sometimes it's not necessary for Child Protective Services to be called. Sometimes it is, but you know, certainly they can be made aware of anything that we're doing as well with your permission. Yeah.
Okay.
That's a good question. I'm glad you're asking questions because this is your plan, and it's not my plan, it's your plan. So
yeah, I actually wrote a list down so I wouldn't forget of things that I wanted to make sure that we went over since this is the last one.
Oh, good. So let's just go through and review where we're at. So we've got you and Dad listed as the household members.
Yes.
And then some of the things that you had mentioned as your goals that you want to work on after the baby's born was breastfeeding and continuing with outpatient.
You're also, I'm sorry, I didn't mean to interrupt you. Since I'm doing the breastfeeding, one of the things this plan helps me with is getting the pump right. Now that we're at the end of it, we can go see about getting a pump now, correct?
Yes. In fact, I contacted a few places to find out who might have a pump. And then once you sign a consent to be able to release your information, then we can kind of coordinate with them to get you connected so that you can have the breast pump.
Oh, thank you so much.
Yep, you're welcome. So continuing with outpatient, and then you and I are going to continue the Circle of Security Parenting. We'll finish that up. The parenting class we've been doing. And then you had mentioned the nicotine patches that you wanted to continue to wean off while you're at the hospital. and keep continuing working with Kathleen at the Upstate Perinatal Center. And then also the baby's pediatrician, we already got that set up. So we got a lot of things in place already for
Also
strength.
love how like a lot of my stuff, you helped me make sure it was like easy on me. Crouse is like dealing with majority of me, like since there's so many different doctors and I have different counseling and therapists and all that, like you made it really easy for me because they're all like based out of Crouse or, you know, right by the area that you're in. So that way it's easy for me for transportation and everything.
That's good to hear, because the last thing you need is a whole bunch of stressors right now at the end of your pregnancy or at the beginning after the baby's born. So I'm glad that it was more stress off your back, because that's the last thing that you need. So some other supports, you know, having a good stable place to live. Baby's dad is a business owner, so he's employed. You have your dad and your stepmom, they're super supportive. And then working with our peer services specialist. You had also said you wanted to continue with the MRT and finishing that group, and working with us an outpatient, but then you also have a really great connection to the local recovery community. And so your support network there, I listed as well.
Okay.
And then some safety and protective factors. So one of the things I listed here was that you are learning some new skills in the parenting class based on attachment theory and child development. And so you'll be able to apply those things. Demonstrating emotional intelligence, being able to identify like the needs of the baby as well as what's going on inside of you emotionally. And you have a great awareness about community resources, because some of the resources on this list you brought to me, you knew about.
Well, actually, that's something I wanted to let you know that's on my little list right here. The resource that you gave me for the car seat, actually, I was really blessed because I called that resource and they referred me to have a doula come to the hospital with me when I have the baby. So, you know, you gave me some really great resources during this.
That is terrific. So you thought you were going for a car seat and you ended up with a car seat and a doula.
Yes, double.
Double. That's super.
Birthright, I know that me and you have discussed talking to them. They gave me a whole package of stuff, like with diapers and clothes and everything.
Mm-hmm. And I believe that we have a pump lined up for you. So I think that we'll be good with that. I just need you to sign a consent, and then we can coordinate the referral for that as well.
Okay.
Because I know that's important. You know, that's a really big need that you have, and that'll take a lot of stress off you to have that in place.
Yes, definitely.
So here, Danielle, we just listed all the, like you said, all the people that you're working with. So we have, you know, the folks that you're working with in maintenance therapy with Tasha and myself, an outpatient, also with Dr. Barry for your psychologist, and then peer services. And then we also, remember, did the Mommy and Me program at Crouse.
Yes, I'm so thankful actually that you're doing this program with me, because with the baby being born on methadone, you know, there is, you know, risks for things. And I think that program is amazing that, you know, you can stay at the hospital, you know, with the baby, even after my discharge, if the baby has to stay longer. That's like amazing.
Well, and it really helps because once you understand neonatal abstinence syndrome and you're able to do some things to help to nurture and calm the baby, and then that prevents the baby from having to go to the NICU oftentimes. So right. You can do lower lighting and you can have your own room, and there's a lot of things in place that'll make it a conducive environment for the baby and for you.
Yes, I think that's such a great thing that's going on.
Yeah, I'm so glad that you wanted to take part in that. So here's where your input comes in. So the circle of security parenting I've listed, and then you had some other things that you mentioned that you were really interested in talking about, that you felt you had some needs that you wanted covered.
We went over the pump, the car seat, all that stuff. also the parenting groups, I was wondering, we discussed if I could be put into one with other women in it.
Yeah, so you, for the parenting, currently, you were the only one doing the parenting class, but I know you were interested in hopefully being part of a group. And so hopefully we'll be able to get a group going so that you can participate with other parents that are learning about the same skills as you.
Okay.
That would be great. So I
And
know
also-
Birthright is giving you a layette set and also diapers. And I believe that they also were the ones that said that they had the breast pump for you.
They're the ones that I just told you previously that they had given me a bag. I went there because you referred me last time we discussed this. I told you that in the beginning of the video. That I went there and they gave me a huge bag of stuff with everything in it. Bottles, burpee cloths, clothes, everything was in there.
Wonderful. And I believe that if you continue to keep in touch with Diane, that she will help you out as you go. Even after the baby's older, she can help you with some of those needs too. So it's not just for now. And then the Lullaby League, that was where you were able to get the car seat. And then you said you actually ended up getting the doula services.
Yes, and right now with all the stress of COVID being out and not being able to know right now what exactly my plan is going to be, because we don't know for sure if I can have, you know, a person come in yet with me in the birthing room. So that's a little nerve wracking, but you know, it's good to know that I do have an doula I've been speaking with who is allowed to be there. So
Wonderful.
that's definitely a stressor that was taken off.
Well, it's so relieving to know that you won't be alone, that there's going to be support people right there at the hospital. Also, the social worker that's at the hospital will have a copy of this plan, and she'll be able to help you as well once you're there. So they can communicate with us so that when you come back to us, if there's some things we need to help you with, we can kind of pick up where they left off. So it's a nice communication system.
Yeah, the doulas actually brought me to the hospital. She brought me a boppy pillow that goes around my belly, and the long cloths that you wrap the baby in. So that was so
swaddler.
sweet. Yes,
Wonderful.
a swaddler.
That's terrific. Yeah, I'm so glad that you are able to ask for help and not afraid to say I have a need, and look at all these needs that you've had met. It's just wonderful to see this all coming together.
I never really, you know, tried to reach out and get help, and you know, I always hear that it's out there, so it feels really good that I actually reached out, because I've been helped so much during this whole pregnancy.
Well, you've been open to it. So I know that we have done some education about postpartum depression. We had done the Edinburgh postpartum depression scale together, and we'll do that again. The hospital will also monitor for that as well. They will help you with the breastfeeding. You and I are doing the parenting class. And the neonatal abstinence syndrome, I know you and I have spent a long time on that, just educating you on what to expect, what things can happen with the baby, and preparing you for some really good ways to comfort the baby and help to lower the stress of the baby.
I'm so glad for that, because you would think with all these different people I'm working with, because if you look at it, I'm working with quite a bit of people. No one really explained to me like you have, you know, what can happen to the baby, you know, after I have the baby.
It gives you some comfort, I think, to know some information, and then you can develop a strategy for how you want to handle it. So do you feel like you have a good command?
Sorry, I didn't mean to interrupt you.
Fine. Go ahead, Danielle.
I was saying them, I read over all them packets you printed for me, them resource packets.
Great. That's super great. And that shows like your interest in wanting to learn and being teachable, you know, and open to what you can do to make it a great experience for both of you. Because if the baby is calm and happy, then, you know, it's going to make it so much more peaceful for you.
Right.
So I wondered, how are you doing as far as where you're feeling in terms of like having everything you need for the baby and having like your hospital bag packed? And that's kind of where we're at. I mean, getting the bag ready
I
and
know we're down to the final straw here. I have everything ready. We got to find out about the breast. We got to still get the breast pump. And I also wanted to see if after I have the baby, if me and you can discuss getting me a like a medical worker who can keep all my doctors like informed with what the other doctor is doing, you know what I mean? So everyone's knows what's going on with me.
so maybe like a case manager that can kind of help you juggle all the medical appointments and outpatient appointments and would talk to each of them on your behalf too. We could certainly do.
Sorry, I'm babysitting.
I hear a little one in the background. So you're
Yeah,
getting some practice in before the baby comes.
Yes, you can say that.
Well, Danielle, I really appreciate that you've taken the time today to do this and to go over this once again. And we'll plan on meeting again next Friday so that we can just go over everything else just to make sure we're all good.
Okay.
Do you have any questions or anything else
I was just looking at my list. I think we answered them all. Oh, yeah. Now I actually have one more question. Actually, after I have the baby, are you still involved with me?
So you and I will keep working together on the parenting classes and also in outpatient.
Okay.
Yeah.
Well, I think that's it.
Great. Oh, he's making some noise, isn't he?
Yes, he's young too.
He has a lot to say. Well, thanks, Danielle. I really appreciate you being here today.
Thank you, Lise. You are such a big help, by the way.
Well, you make it easy to help you.
I'm definitely blessed for all of this.
You take care, okay?
Thank you.
Bye-bye.
Bye.
So hopefully everyone found that video helpful in how to actually go about implementing a plan of safe care. So my name is Alexandra Punch, and I'm the Associate Director of the Lerner Center for Public Health Promotion at Syracuse University. And now that you've learned a little more about what a plan of safe care is and how to help moms and babies, I'd like to spend a few moments going over some statistics that further explain why a plan of safe care is so important. So as you can see from this slide, I'm going to quickly review what is happening on a national level surrounding NAS and child removal. As the slide points out, incident rates of NAS are rising, as are costs associated. There's also been a concerning increase in the prevalence of alcohol and other drug use as a contributing factor for child removal. As you can see, research that was recently published in JAMA indicates that between 2010 and 2017, the national incidence of babies born with NAS increased 82%. And the number of mothers with an opioid-related diagnosis at delivery increased by 131%. However, it should be noted, and I'm going to discuss this further in a different slide, the rates of NAS and opioid-related diagnosis vary greatly by state. For example, Nebraska's NAS rate is around 1.3 per 1,000 births, and West Virginia's is 53.5 per 1,000 births. So there's a lot of variation. As many of you may be aware, it costs significantly more to treat a newborn with NAS than it does a baby without. As the graph shows, a hospital stay for a baby with NAS is nearly 9 times more than that with a baby without. Nationally, around 82% of all NAS treatment costs are charged to state Medicaid budgets. There are, of course, very human reasons that we would want to decrease NAS diagnosis in the US, but we also can't ignore the financial implications as well. So to me, this is a really important slide because, as we have learned, one of the biggest reasons for implementing a plan of safe care is to keep mother and baby together in the home. SAMHSA has reported that between 2000 and 2016, parental alcohol and drug use as a contributing factor for child removal has increased almost 17%. If we look at similar data, we see that most reasons for child removal from a home have decreased, such as physical abuse, sexual abuse, and child behavioral problems, while parental, alcohol, and drug use, neglect, and incarceration are increasing. Additionally, children under the age of 5 represent over 41% of children entering the foster care system, with a significant portion of them under the age of 1. As I previously mentioned, NAS rates vary greatly among states. This graph depicts the variation of child removal as alcohol and drug use is a contributing factor by state. As you can see right over here, New York is doing better than a lot of states, but there's still a lot of work that needs to be done. So speaking of New York, let's move on to some local statistics. So what's happening here in Central New York? To those of you that are not from Central New York, I apologize, but as you'll see with our data, you can just assume that wherever you live is most likely doing a lot better than us. So some quick takeaways is that CNY has among the highest incidence of NAS in New York State. Western New York and Mohawk Valley are second and third, and the majority of medical costs associated with NAS were paid by Medicaid or a Medicaid managed care plan. So as you can see, Central New York and Onondaga County have pretty high rates of NAS compared to the rest of the state, with Onondaga County reporting NAS birth rates at 35.2 per 1,000 births. As my previous slide mentioned, costs associated with NAS hospital stays are an average of 9 times more than a baby born without NAS. A lot of this has to do with the length of stay a baby with NAS requires in the hospital. Data from Crouse Health indicated that the average length of stay for a baby with NAS is 16.8 days, compared to 2 for a baby born without. And lastly, just to wrap things up, as I previously mentioned, the majority of medical care costs associated with a baby born with NAS are paid by Medicaid or a Medicaid managed care plan. This means that most mothers and babies that could benefit from a plan of safe care will be low income and most likely underserved. Now, that isn't to say that only this population needs a plan of safe care, but because we know that substance use spans all socioeconomic statuses, but many of these mothers may not have the same access to interventions, which is why a plan of safe care is so vital and so important to changing these statistics and the lives that they represent. So thank you so much for your time. And now I'm going to let Dr. Ajabi work his magic in teaching you about opioid use disorder and pregnancy.
Hi, so my name is Talani Ajabi. I'm the Chief of Psychiatry at Crouse Hospital. I also serve as the Medical Director of Chemical Dependency here at Crouse Hospital. So I was hoping to talk about some basic concepts in addiction, and also to try and connect this with the topic of the day, which is the plan of safe care, discussing the impact of opioid addiction in pregnancy. Following the objectives of today's discussion or today's seminar, addiction as a chronic disease, the risk factors for opioid addiction, neuroscience of addiction, or opioid use in pregnancy, treatments, medication-assisted treatment in pregnancy, and lastly, the opioid overdose and Narcan treatment in opioid overdose. So first of all, trying to define addiction. So a consortium of medical organizations, American Pain Society, American Society of Addiction Medicine, and American Academy of Pain Medicine define addiction as a primary chronic neurobiological disease with genetic, environmental, and psychosocial factors influencing its development and manifestations. 2 words I really like to point out to you as the first of all is primary. So basically what that suggests is that the problem is basically starting from the brain. The site of the origin of the problem of addiction is actually starting in the brain itself. And also chronic, one thing you know about chronic medical diseases is that they are not curable. They're not curable. They can be treated, they can be controlled, but they cannot be cured. So they go through under certain circumstances, a patient that suffers from a chronic disease will be in remission, and also under some stressful circumstances, they might relapse. So there's so many conditions that qualify for this. If you think about other chronic medical conditions we could think about, hypertension, diabetes, asthma, multiple sclerosis, Parkinson's, cancer, lupus, you think about all those things, you will know people who for a very long time are doing well, and sometimes they have a flare or a remission or a relapse of their condition, and they will need more treatment. The same picture is what we see with addiction as well. Those a typical average person that struggles with the disease of addiction will have a period of time when they're doing well, and under certain circumstances they relapse. So we want to talk a little bit about why. One of the core features of addiction is just that they're uncontrollable, they're compulsive use of a substance or engagement in a behavior despite repeated consequences. So this is mostly out of the control of the patient. And obsessive, when you hear the word obsessive, compulsive, you think about OCD, obsessive compulsive disorder. If you think about somebody that suffers from OCD, you know how disruptive it is when someone suffers from that disease. It's almost the same thing. So just wanted to point that out. When it comes to specifically opioid addiction, the definition is problematic use of opioid in such a way that causes significant distress and impairment to the person who suffers from the addiction. So not everybody that uses opioids suffers from opioid addiction, but when it becomes if it becomes problematic, that's where the issue is. Next. So this is a slide just of a study that was done some years back, looking at comparing the relapse rate of different chronic medical diseases and comparing it to the relapse rate of addiction. So what you see is that addiction is actually comparable to hypertension, diabetes, and asthma. It actually does better than hypertension and asthma in terms of relapse rate. So when you think about relapse, this is a time when patients become more symptomatic and they need some kind of intervention. So you're going to see, so what that study shows is that you see more relapse amongst patients who suffer from hypertension and asthma than you actually see with addiction. So, and diabetes is a little better. But basically what that tells us is if you have a patient that suffers from these other medical conditions, and when they have their relapse of their condition, we do not judge them. We just treat them, we take care of them, and we get them stable again, and they can just start living their meaningful lives and be symptom-free. That is the same approach we have to, if we truly understand that addiction is a brain disease, we have to have the same approach to treating addiction. So rather than dealing with the behavioral, just focusing on the behavioral part of addiction and try to judge people as being like losers or somebody who has some kind of moral failing, it's actually best to see it as a disease and understand that it's comparable. Somebody who has diabetes, so a lot of people who have diabetes still engage in, behaviors that are not consistent with the healthy living if you have diabetes, and yet we still take care of them. So we want to push more to have people approach addiction the same way. Next slide. So just for the understanding how addiction works, I felt like we should talk a little bit about the brain and how it works. There are two things to look at when it comes to the brain and addiction. First, what is going on? How do people end up being addicted to substances? Not everybody who is exposed to substances become addicted to it. So as a matter of fact, if for instance, cocaine, 1 out of 6 people who are exposed to cocaine become addicted to cocaine. So what studies have shown is that the earlier the onset of exposure to a substance, the higher the risk of becoming addicted to that substance. So, and what you will see is that the brain is developing, the brain development goes on from birth till the brain maturation, actually, I should say, goes on from birth to the age of 25. During this time, there's so many changes, some of them chemical, some of them structural changes going on in the brain, and is a very sensitive environment for neuron formation and synapses and circuits and everybody trying to figure out what function they're going to be serving. And if you introduce a drug during that period, it's going to cause a lot of distortion in the neurochemistry of the brain. So the brain develops in such a way that it's dependent on those substances for its normal functioning. So studies show that about 2/3, about 67% of people who become addicted to a substance are already exposed to the substance by the age of 17. And by the age of 25, when brain maturation completes, about 85% of people who are going to be addicted to those substances are already exposed. So you can imagine that when people were still adolescents and teenagers, and that we sometimes can be irresponsible, they're already exposed to these substances. And if they have other factors in place, including the genetic factors, they're more likely to develop an addiction down the road. So, and I don't know how much we can actually put to, well, they should be in control of what they're doing. They should know better. They should do this. That's a look for an average teenager, that's difficult. And why is that difficult? It's because if you look at all the structures in the brain, if you're familiar with the neurobiology of the brain, all those structures you're looking at, they develop, there's like the brain develops from the back and from under upward and to the front. The last part of the brain to develop is the frontal part. And if you think about what the frontal part of the brain does, is the one that controls logical thinking, is the one that controls our poor impulses, is the one that gives us good judgment. So decision making, the risk assessment, calculations, executive function, those are the things the frontal part of the brain does. And this is the last part of the brain to develop. You can imagine all those other primitive areas, or areas that control aggression, pleasure, emotions, and all that. All those are already developed way before the logical part of the brain develops. So when people are exposed to substances, sometimes they're not capable of even being able to understand the risk they're up against, be able to exercise good judgment. I know those of you who have teenagers at home and who have family members who are teenagers, sometimes you feel like you're telling them things and they're not getting it. I think they think you're old, you just don't know, you're not cool, that kind of stuff. It's because they're not, even biologically, they're not capable of synthesizing a lot of information you're telling them. Now, if you now say by the age of 17, 67% of people who are going to develop the addiction are already exposed, then that becomes a problem because they're exposed to the substances. They already have the risk of the addiction, and their brain is not developed enough to be able to say, well, this is not good for me. If I keep going this way, I might not be able to do well in school. I might go to jail. They can't think that way. So I just wanted to point that out. Next slide. So this is a functional imaging study that shows the development of the brain from the back to the front. So those yellowish green areas are the undeveloped or underdeveloped areas, and you see the bluish areas are the developed areas, and you see how as it goes from the age 5 to age 20, how the blue is filling out from the back to the front. So that's the way the brain develops. Next slide. So the things I was talking about with specific areas of the brain, there's a part of the brain called the nucleus accumbens. Is the only one I'm going to talk about so I don't bore you too much. That's the pleasure center in the brain. It's called the nucleus accumbens. Anything you enjoy doing in life, if you enjoy exercise, you enjoy food, if you enjoy sex, if you enjoy watching a movie, any form of pleasure that you have, it's because you are, there's some changes going on in the nucleus accumbens with the release of dopamine. And the amount of dopamine that you're releasing in your nucleus accumbens is the degree of pleasure that you experience. And sometimes when you use substances, the degree of that euphoria is even high and very intense. So somebody who's already addicted to substances may not be able to have the same kind of pleasure from food or from spending time with you. So this is some of the kind of dangers that people encounter when they're addicted to substances. It's like the way they enjoy life, the way they experience pleasure is so intense that nothing else can match it. So they don't enjoy food, they don't enjoy sex, they don't enjoy the basic things that other people enjoy. Go on, next slides. So I was talking about the risk factors for addiction. I mentioned earlier the genetic predisposition. The genetics is huge in addiction. About the risk of addiction is about 40 to 60% genetic, which means some people on the day they're born, they're already wired in such a way that they have a high risk of developing an addiction. So all they need is the exposure to the substance, and it starts a vicious cycle that they're not able to stop. So that's why some families, you see generations, 3, 4, 5 generations straight developing the same addiction, or even having cross addiction where they're addicted to another substance. But you see addiction just kind of engulf a whole family because they already have the genetic predisposition. Another risk factor for addiction is the prior history of substance use. So if somebody has used other substances in the past, they have a risk of becoming opioid addicted. So if somebody smokes marijuana, we all talk about marijuana as a gateway drug, you have 3 times a higher risk of becoming addicted to opioids, especially heroin, than somebody who doesn't smoke marijuana. So, and the list goes on and on. If you're addicted to pain pills, you have a 40 times risk of developing addiction to heroin. It's stuff like that. One substance puts you at a risk of addiction to opioids and other substances. Co-occurring mental illness. Some people use drugs to self-medicate. So depending on what kind of mental illness somebody has, if I have depression, for instance, it's likely that I can use any substances because all substances cause euphoria. So euphoria is the antidote in a way to depression. So they can use any substances to self-medicate depression. If I have anxiety or I have mania, these are activated states, right? I want to use something that can calm me down. If I have bipolar disorder, I'm always manic, or I have anxiety, I want something to calm me down. So I'm using things like opioids, like benzodiazepines, like alcohol. If I have ADHD needs stimulants for focus. So you're going to see somebody who has ADHD, if they don't have access to good medications, they're going to be addicted to stimulants. So it's on and on like that. People with personality disorders, because of all the mood swings, borderline personality disorder, antisocial personality, narcissistic personality, they experience a lot of anxiety, mood swings and all that. You're going to see them self-medicate with alcohol, with opioids and stuff like that. People with history of trauma, whether physical, sexual, emotional trauma, the best way to numb yourself from physical and emotional pain, well, don't let me say the best, the easiest way is to use drugs, because those opioids will put people in bubbles. They isolate you, disconnect you emotionally from your trauma. They feel some kind of transient relief, but on the back end, there's a lot of, the outcome is eventually is going to be very, very bad. So people would sometimes use substances just to numb their pain, the emotional pain, the physical pain. So we always like to screen for PTSD amongst our patients. The literature says about 70-75% have PTSD. From my clinical experience, is upward of like 95% of them, whether it's from early trauma or trauma as adults during the course of the use of substances. So like I said before, the earlier the onset of substance use, the higher the likelihood that somebody's going to become addicted to it. It's been proven for almost every substance. So that's a given. Psychosocial risk factors, somebody who is unemployed, financial difficulties, they're homeless, they have poor family and social network. Those are things that put people at risk of addiction or put them at risk for continued use of substances. Talking a little bit more about the neuroscience of addiction again. Okay. So that area I was pointing out, I was talking about before, it's called the nucleus accumbens, is the pleasure center in the brain, is in the midbrain. It contains dopaminergic neurons and it releases dopamine. So anytime you are doing something that's pleasurable, is because there's activation of the nucleus accumbens and dopamine is being released into that area of the brain. So there are different drugs that act on different parts of the brain, which now act in effect to activate the nucleus accumbens. They project neurons to the nucleus accumbens. Nucleus accumbens responds by releasing dopamine, and that's how people experience euphoria. Some drugs act directly on the nucleus accumbens. So the overall goal of a lot of treatment is to block this response, block the effect of the nucleus accumbens. They will block neurons that project to the nucleus accumbens or block the nucleus accumbens itself so that you're not able to release dopamine when you use drugs. That's the basics of anti-craving treatment. So when we attack craving, the goal is that we don't want you to experience euphoria if you use this drug. And if you don't experience euphoria, the law of diminishing returns will say you're going to keep using less and less because you're not enjoying it anymore. So that's the goal of those types of treatments. So anything, like I said before, anything that you enjoy doing is because you're releasing dopamine in this part of the brain to varied amounts. And the treatment sometimes the goal of treatment is to block that response where you release dopamine and experience euphoria. We block that euphoric feeling. Go ahead, next one. I feel like I'm just going to talk a little bit about this one. The summary of this is that there's certain areas of the brain that have been primed. When somebody is using substances on a regular basis, there's some changes that already happened in the brain such that when they stop using those substances, they will be okay. Those areas are cool, they're fine, but the re-exposure to the substance. So the condition cue restatement means restatement basically means relapse. So the condition cued relapse means you start people, places, and things. So you start once you get exposed to people you used to get drugs with in the past or used with in the past, or places that somebody has used in the past, or paraphernalia that they've used, or things that look like paraphernalia. Somebody who uses powdered cocaine, who snorts cocaine, if they see ordinary powder, face powder, it can trigger them. So it's because once you're exposed to those things, people, places, and things, there's certain changes that happen in the brain. The amygdala is the fear center in the brain, is the anxiety center in the brain. That is where the reaction first starts. The amygdala starts going off, and the anxiety, it builds a lot of anxiety. That leads to a lot of cravings. Then this drug-seeking behavior starts, and patients eventually relapse. So these things are already primed. So these are changes that already happen in the brain. This is not the self-will of the patient to just go and relapse and use and get high and all that. No, these are things that are already primed. That's why part of the treatment also is to remove them from the triggering environments by triggering associations in their lives. Drug priming restatement basically means some people will say, oh, okay, I've stopped drinking beer, alcohol for the past 10 years. I'm just going to drink a can of beer today with my friend who's visiting from out of state, just one can of beer. And at the end of the day, that beer, once you get that beer in place, that one triggers use for the use. It triggers a craving. Now you've exposed the brain to that alcohol sensation, and it triggers more cravings. As a result, the person is not able to stop. You end up going several days of binging from just wanting to use one time. So that is called drug priming relapse or drug priming restatement. Then sometimes it's stress-based. So under stress, certain hormones and chemicals are released in the brain, and the corticotropin releasing hormone and all the hormones are released in the brain that ultimately lead to a state of anxiety, and the anxiety leads to cravings and then drug seeking behavior and drug relapse. Next slide. Now going down to opioid use in pregnancy. So this is what the numbers look like. I mean, the latest numbers I have, 2% amongst pregnant women of reproductive age use opioids. About 0.4% to 0.8% use opioids during pregnancy. According to the CDC, 7% of women report using prescription opioid pain relievers during pregnancy. So basically what we've seen is that over the past decade and more, there's been an uptick in just opioid addiction, opioid use in general across board, maybe from prescription practices, maybe also from potency of the changes in the potency and the consistency of the drug that's being sold. We're having more opioid use and more adverse consequences of opioid use, including overdose and others, and also the issue with neonatal abstinence syndrome and all in pregnancy. Alex shared it earlier on about 131% increase in opioid-dependent pregnant women presenting to the hospital for delivery. So there's been a very big uptake over those years, about 7-8 years, to 2010 to 2017. And also the neonatal abstinence syndrome rate is also going up. It went up in that 10-year period, it went up more than 5-fold, and it continues to go up. So that is based on like the changes in the opioid availability, and also the potency of the opioids that are out there right now. What are the opioid effect in pregnancy? There's some effect on the mother, there's some effect on the baby. The most serious effect you're gonna get from opioid, especially illicit recreational opioids, is the issue of withdrawal syndrome. So a mother who is addicted to opioids on the street goes through on and off chaotic opioid induced opioid-related withdrawal. So sometimes they're stable, they go back into withdrawal, they're stable, withdrawal, stable. Sometimes they go through this chaos multiple times in a day. So this causes a lot of uterine instability. There's changes in the mother's blood pressure, and there's a pulse rate, the tachycardia, hypertension that they experience that affects the blood supply to the baby and oxygen supply to the baby. Ultimately, sometimes they put the baby in distress, and sometimes it ends up causing even a miscarriage for the mother. The mother goes into preterm labor and delivery. So the things that happen, the placenta becomes insufficient, it's not supplying blood that it's supposed to be supplying, because the blood pressure, the mother's blood pressure is so high or so low, the baby is literally suffocated because the baby is not getting oxygen, and eventually the baby may die, or you have a preterm delivery of a premature baby. So other things, preeclampsia and eclampsia are very dangerous in pregnancy. Typically, they will happen like a late second or trimester or third trimester, I believe. It can be dangerous for both the mother and the baby. Intrauterine growth retardation, low APGAR score babies. The big one is neonatal abstinence syndrome, is more common with people who are using recreational opioids off the streets, heroin, pills, fentanyl. But you also see with people who are maintained on methadone or buprenorphine for treatment, but it's much, much, much less and better controlled when it's from treatment, not from recreational use on the street. Then the issue of birth defects, in the past we've said, opioids are not really associated with too many birth defects, but there's been recent studies that have seen a lot of birth defects, especially relating to things like intellectual functioning, language problems, communication deficits. So now there's more studies being done to look into what other birth defects we're seeing. Now, because of the changes on the kind of opioids that people are using out there on the streets, we're having more and more adverse consequences of the use, even in pregnancy. So other issues of a pregnant woman who has opioid addiction, poor nutrition, because of the chaos of using and running the streets and trying to get just a general chaos that comes with substance use, recreational substance use. There's poor nutrition for the baby. They tend to not engage in prenatal care, even if they start. Sometimes they start missing appointments, or sometimes they just don't seem interested in doing it. So we have to continue to encourage the mothers and stay on them, even if you have to make appointments for them, even if we have to reward them for doing it. So sometimes poor prenatal care can be an issue, even when they're in treatment. How much more when you're not in treatment? Intimate partner violence and trauma. So that's the story of a lot of women. Sometimes they're pregnant by men who are irresponsible enough to say that, they don't even accept the child, or they don't want to be part of the pregnancy, or they're not supportive during the pregnancy. And sometimes they're with the men, and the men tend to be abusive, sometimes violent. So all these things put the mother and the baby at risk. Dangers from drug-seeking behavior, activities like violence and incarceration. Those are issues that also can come up. Social issues like poverty, inadequate housing, poor family and social support. These have been actually studied, and they're more common in women who are pregnant and opioid addicted than women who are pregnant and not. So I talked about the dangers of intrauterine withdrawal earlier on. So mother is addicted to opioids, but because they don't have the regular supply, because of the short-acting nature of the opioids, the erratic way opioid withdrawal, they start having we call it hemodynamic instability, hypertension, tachycardia, poor blood supply to the baby. All these ups and downs can be problematic. It cuts off blood supply, cuts off oxygen supply to baby. Baby is in distress. Sometimes baby dies, or maybe mothers go into labor too early and have a premature baby. And that comes with a lot of its own complications when you deliver a premature baby. Now, to talk specifically about treatment, the treatment for opioid, a mother of an opioid addicted baby can be either medication, should be a combination actually of medications and also behavioral treatment and counseling. When it comes to the medication part, there are two types of ways to do. Medication assisted treatment basically means somebody is addicted to opioids and you're taking them from this short acting rapid onset, short acting opioids, which promotes addiction, to a long acting, slow onset opioid that is safe and therapeutic. So if the patient if you need an opioid to stop their withdrawal symptoms and to prevent them from going into having cravings, you give them an opioid that stops that. But it's going to be a safe opioid that doesn't have any that shouldn't have any adverse values if it's done the right way. So medication assisted treatment means they are maintained on opioid regularly. They take the opioid every day so that they never go into withdrawal and they don't have cravings. Once a patient gets to the therapeutic dose of whatever opioid we're using for medication assisted treatment, whether it's methadone or buprenorphine, they don't go into withdrawal. And once they get to the therapeutic dose, even if they use any other opioids recreationally, they don't experience any euphoria from it. So it's safe in that way. On the other side, there's also medically supervised withdrawal, which is only recommended if mother vehemently declines to be maintained on opioids and you don't have a choice. They don't want methadone, they don't want buprenorphine, and you don't have a choice, then you can do medically supervised withdrawal. Or maybe there's no access, there's no way around where they can get to an OTP, opioid treatment program, and get methadone or buprenorphine, then you won't have a choice. Those are the conditions under which medically supervised withdrawal is allowed. Medically supervised withdrawal, and this is because the MSW can be dangerous because the patient tend to relapse after they completed treatment. So what they typically would do is, this is how the treatment works. Somebody is addicted to heroin, they try and start them on methadone, for instance. They treat them on methadone for a few days until they're stable. So they're stabilized on methadone, they stop using heroin. Then over the next few weeks, you start tapering off the methadone over a few weeks. And at the end of it, the woman is opioid free. They're not using heroin and they're not on methadone. But what tends to happen is in a few days or weeks after that, they relapse again, they go back to recreational opioids. So that's why it's dangerous and it has a lot of adverse outcomes. But if you don't have a choice, it's better than nothing. But if you don't have a choice because there's no access to MAT or there's or the person is not willing to do MAT, then that can be done. So like I said before, MAT, the goal of MAT is to eliminate or prevent withdrawal symptoms and also to reduce or eliminate cravings and improve the functioning of the mother. Traditionally, there are three types of MAT, methadone, buprenorphine, and naltrexone. Naltrexone is not an agonist opioid, so it's only an anti-craving treatment for opioid addiction, but it doesn't do anything for withdrawal. People are not often motivated to be on it. They need a lot of external motivation to be able to do naltrexone, and it's not recommended for pregnant mothers because first of all, it's not been studied to be safe in pregnancy. And the second of all, it puts the mother at the risk of overdose because sometimes they relapse to go back to recreational opioid use and they feel the need to override the effect of the naltrexone. Is not recommended to ever get distilled to use methadone, and in some cases, it can use buprenorphine. Methadone is the closest thing to the recreational opioids that we have. It has about 88% activity at the opioid receptor, heroin is about 84% and fentanyl is about 90% in the degree of activation of the opioid receptors in the brain. So methadone is the closest to them. Buprenorphine has only 40% agonist activity. That's why when you compare Suboxone and methadone, you see like it has about half the efficacy of methadone. And methadone is always associated with an increase in retention in treatment compared to buprenorphine. People tend to stay more in treatment when they're maintained on methadone than buprenorphine. Naltrexone has zero agonist activity, so it's the flat line down there. Who is appropriate for MAT? For buprenorphine, is you only need to meet criteria for opioid use disorder. So if you have a DSM-5 book and you screen them with all those 11 symptoms of opioid use disorder, if a patient has 2 symptoms, 2 to 3 symptoms, they qualify for, they refer to as mild opioid use disorder, and that qualifies them. Moderate, severe, moderate is I think about 4 to 5, and severe opioid use disorder is 6 and above. Methadone, on the other side, on the other hand, you require at least 1 year. The duration is important for methadone, at least 1 year of opioid dependency or addiction. Whether it's continuous 1 year or fragmented, you need at least 1 year. But sometimes we may have situations where a patient is has been using opioid less than 1 year, but they're using so much, or there's so much chaos in their life, they're so unstable that buprenorphine will not help so much, or maybe they use intravenously and they're using so many bags of heroin or something like that, that you know that methadone will be best for this patient, but they don't have up to 1 year. We're able to apply for a waiver with SAMHSA, with a federal agency responsible for addiction. It's called the Substance Abuse and Mental Health Services Administration, and we get an approval to actually treat such a patient with methadone if necessary. Naltrexone, like I said, is not recommended for pregnant women, but if you have to treat non-pregnant subjects with it, is also the person just needs to meet criteria for opioid use disorder. What are the benefits of this kind of treatment in pregnancy? What studies have shown is that the women who are maintained on this treatment, they don't relapse on recreational opioid use, or if they're using, they cut down significantly on the amount they're using. There's lower risk of relapse if they already stopped. There's lower risk of transmission, so both to the mother and also from the mother to the baby. Increased engagement in healthcare system, including prenatal care. Sometimes you have patients who already have hepatitis C. We have a study that we're doing here in our program before that showed that people who are maintaining MAT tend to be more compliant with treatment for hepatitis C, or even HIV. The studies have shown that as well. For the baby, it's just uterine stability. The uterus is stable, baby is stable, baby is being nurtured, nourished, they're getting good oxygenation, good blood. So you expect this kind of baby to go full-time, go all the way to the end, and that they're healthy. When you're maintaining on MAT, the risk of neonatal abstinence syndrome is only 50%. So a lot of mothers will go to the hospital and their babies don't even have an NAS. They just go home right after delivery. So it's safe, it's effective that way. I mean, there's no way to predict whose child is going to have NAS, but some do, some do. All right. So what is neonatal abstinence syndrome? These are the features. This is a baby of opioid addicted mother. Because the baby has been exposed to opioids throughout the pregnancy, they become dependent on opioid as well. And as a result, when they're born, they go into opioid withdrawal. These are the symptoms. It's the uncontrollable, restless, agitated baby who will have like muscle spasms. They can have seizures, myoclonic jerks. They have some respiratory distress symptoms. Sometimes they have difficulties feeding, maybe sucking, or if it's not well cared, it's not well taken, this might be a child that will develop failure to thrive very quickly. They're regurgitating food, projectile vomiting. But the people who the neonatologists who take care of them, they're very good at controlling these symptoms. You see the timeline as is different from heroin and methadone. It tends to happen very quickly for people who used heroin throughout pregnancy and now have NAS, but they have a higher risk of developing NAS, and the babies tend to have higher symptoms of NAS as well. But methadone maintained babies, even though it's delayed, the severity of the symptoms is lesser compared to recreational opioids. What's the treatment? Nurse the baby in a quiet environment, minimize stimulation to the baby, administer morphine, like the morphine taper. So they start the baby on a certain dose of morphine and they taper over several days, just like something like a detox. So, and that affects the length of stay. So I think I'll talk about that next slide. So comparing methadone and buprenorphine, the methadone has been well studied. Like I said, is the gold standard for that treatment. Buprenorphine is only partially studied. But what we've seen so far is that methadone and buprenorphine are comparable in treatment. So if a patient is already on buprenorphine or Suboxone, what we need to do when they get pregnant, if the mother gets pregnant, is that we switch the mother from Suboxone to Subutex, which is buprenorphine alone. It's safer in pregnancy than to give Suboxone. But the only way methadone is found to be superior to buprenorphine is in the retention and treatment. Mothers who are maintaining methadone tend to stay longer in treatment than mothers who are maintaining buprenorphine. The only caveat to that is that when the studies are done, they only compared maximum doses of buprenorphine to moderate doses of methadone. So I think that we need to always talk about that, because if somebody is doing need a very high dose of methadone, it's very likely they won't do so good on buprenorphine. But the ways in which buprenorphine is better is with NAS. Babies of mothers who are maintaining buprenorphine tends to have lesser severity of symptoms. They have lesser requirement for morphine in the hospital, and the stay is shorter. So for the stay for buprenorphine is average of 9 days. For methadone, it's average of 17 days for the baby after delivery. So those things need to be known. And methadone has a lot of drug-to-drug interaction, especially with what we call the downers, the CNS depressants. We have fewer drug interactions with buprenorphine. So when somebody is maintained on methadone, it becomes dangerous to use things like benzodiazepines, alcohol, other opioids. But those things are still a problem with buprenorphine, but they're not as terrible as when you're on methadone.
Other people.
So we're talking about pain management. I'm just going to talk about this in a little bit of a summary. If you have somebody who has an opioid addiction, a new onset acute pain, if you can please try non-opioid analgesia first. It's the desired thing to do. The patient is presented with acute pain, try non-opioid analgesia, especially for mild to moderate pain. But sometimes you anticipate severe pain in a patient and they're already maintained on methadone or they already maintained on buprenorphine. At the dose of methadone buprenorphine that they're at, they are already tolerant to those doses. So they were going to need an extra dose of a short course of opioids for any acute pain control that you need. So if you're taking a patient for a cesarean section, or you have to do an appendectomy for a pregnant woman, you have to remove the appendix. We want to make sure that you give them extra opioids, the same amount, the same way you would give somebody else who is not opioid addicted. Don't think because they're on methadone, they already have some pain control. No, they're tolerant to that dose for pain. It does not work for them for pain. As a matter of fact, sometimes they would have developed a condition called opioid-induced hyperalgesia, where because they've been taking opioids for so long, they're more pain sensitive now. So you may actually need a higher dose of pain medication for them than you need for somebody else. So please, it's dangerous. It's equally dangerous to be over-prescribing opioid pain medications for people to be under-prescribing it. Because when you under-prescribe, the patient will find a way to get on the street to get heroin or something to help with their pain. So if the pain is mild or moderate, you can get away with, the Motrin or Tylenol or Toradol, those types of things, NSAIDs, great. If you're not able to do that, if you have to use opioids, if that's the option, give them adequate analgesia, and that helps. If it helps the addiction, doesn't make it worse. If it's chronic pain, somebody coming with some autoimmune problems or cancer, or not cancer, because cancer you can use opioid, but maybe fibromyalgia, stuff like that, please try other ways. If you can go to the next slide, of treating their pain. The next one. Find other ways of treating their pain without using opioids. You can use those. Next, you can use the non-steroidals and non-opioid analgesia. You can use anti-epileptic medications. You can use antidepressant, things like Cymbalta, duloxetine. You can use imipramine, desipramine, or tricyclic antidepressants. Some people will need, you may even have to go into procedures like doing regional blocks to control pain if you don't want to use opioids. You can use acupuncture. There's so many methods of controlling for dealing with chronic pain that doesn't require you using opioid medications. But for acute pain, especially if they're already opioid addicted and maintained on maintenance treatment, please give them adequate short course just for a few days of analgesia to control their pain. So management of intrapartum pain during delivery, treat like any other pain. I think I already talked about all this. Next slide. So these are the different non-pharmacologic and pharmacologic ways you can deal with chronic pain. Muscle relaxant, you can prescribe muscle relaxant, baclofen, tizanidine, local topical applications. There's so many different ways. Next slide. So this just talks about the changes that happen in pregnancy that we require that we make adjustments to doses of pregnant women when they are maintained on methadone or buprenorphine. In pregnancy, there's a huge expansion in the volume of blood, which so there's a lot of water retention in the body of pregnant women, and that has a dilutional effect. It dilutes the concentration of the medication we're giving them, so we have to increase the doses of the medication we give. And also, pregnant women tend to metabolize drugs faster. It's like the pregnancy itself is eating up some of the medication as well. So because of these two things, rapid rate of metabolism and also the expansion in volume, we have to compensate by increasing the doses of the medications they're getting. So you see about 30% increase in the dose of methadone in pregnancy. And sometimes because they're rapidly metabolizing, they will have symptoms at night. So when somebody comes to drink the methadone in the morning, in the evening, they're already having symptoms. And if we try to increase the morning dose, keep increasing it, it might be too toxic for them in the morning, and yet they're having withdrawal in the evening. So what we do is that we split the dose into two. Take some part of it in the morning, and you take another part of it in the evening. So we make accommodations for pregnant women like that. Next. Breastfeeding is safe in pregnancy for people who are maintained on methadone or buprenorphine. If you have only about less than 1% of the mother's dose crosses into the baby in the breast milk. And this is only enough to soothe the baby. It doesn't increase the baby's risk of becoming opioid addicted or developing dependency. No, it only helps to soothe if baby has had neonatal abstinence syndrome, it helps to soothe their symptoms, to feel better. So just a small amount of methadone crosses. And buprenorphine is also poorly absorbed when it's swallowed, even in adults. That's why people don't take Suboxone. They don't swallow Suboxone because it's poorly absorbed and it's degraded when it goes inside the stomach. So what basically, when the baby swallows breast milk that contains buprenorphine, it's very poorly absorbed. It doesn't do much to them. It doesn't do anything to them. So it is safe to breastfeed the child when you're pregnant. It is safe and it encourages mothers to bond with their child. And also there's a reward, there's a rewarding feeling that goes to the mother from being able to breastfeed their child, unless they have contraindications to breastfeeding. Like if your mother is HIV positive, uncontrolled HIV, you may have contraindications like that to breastfeeding. But in the absence of that, we always encourage mothers to breastfeed their child when they're on methadone or buprenorphine. Next. I think I just explained this. It reduces the rate of NAS and the length of stay in the hospital. So it's a win-win situation for mothers to breastfeed their children when they're on methadone or buprenorphine. Next. So talking about opioid overdose and Narcan administration, opioid overdose, there's an increasing amount of opioid overdose issues that we're dealing with. I think the highest point of opioid overdose was about 3 years ago when we had about 72 49,000 people died from overdose. That's like 2/3 of the people who died from overdose across board were from opioids. So 49 people died from opioid overdose in 2017. I think 2018 was about 68,000. And I don't know if we have 2019. I don't think we have the exact number for 2019 yet. But the numbers have been terrible since fentanyl came on board in 2013. And it's also the pregnant women are not spared of this. So you think about amongst all pregnancy-associated deaths, up to 1 out of 5 are due to opioid overdose. So this is a very prevalent problem in mothers who are addicted to opioids. And it's a very, very difficult situation because when you knock on the mother, you put the mother in withdrawal and the baby in withdrawal as well. But what can we do? Because knocking crosses the placenta to the baby as well. But we always have to go for after the mother's life first. So opioid events. And what we also see is that opioid overdose events tend to decrease as the pregnancy advances. So you're going to see the lowest amounts of opioid overdose during pregnancy in the later part of pregnancy from 7 to 12 months. Then after the delivery of the baby, it starts spiking again. The rate amongst mothers who are maintained on methadone and buprenorphine is lower than mothers who are not. So if you're using recreational opioids, is more likely you'll see opioid overdose with those types of moms than mothers who are maintained on methadone or buprenorphine during pregnancy. Next slide. So this is what I was explaining to you before. So if you look at the rates, the opioid overdose rate by 100,000 persons, in the first trimester, you see how it looks. In the second trimester, it drops precipitously because as the pregnancy advances, the pregnancy starts taking the meaning to the mother. In the first trimester, a lot of people don't even know they're pregnant. So they're still living the chaotic lifestyle or using on the streets, or even when they're in programs still using. But by the second trimester, third trimester, the pregnancy is taking a meaning. Mother doesn't want to harm the baby. They're trying to figure out means of keeping the baby safe. And you see overdose rates drop. But after they have the baby, because of all these changes that happen after a mother delivers a baby, the hormonal changes, postpartum blues, postpartum depression, and also resources. Sometimes the resources are available to the mothers when they're pregnant. Some of them are no longer appropriate now that they've had the baby. So I think that's part of what the plan of safe care is about, to ensure that resources continues to be available to the mother even after they have the baby. So, but you see how the progression goes. The maximum rate of overdose is towards a year after they deliver the baby. Next slide. These are the symptoms of overdose. I'm sure almost everybody here, if not everybody, is familiar with what opioid overdose might look like. It can be dangerous. The most common cause of death is respiratory depression that the mother suffers from opioid overdose. Next one. So lastly, the treatment is to administer naloxone. There are different ways to administer it. The most common way is our prepackaged intranasal administration. Now they're 2 milligrams. Most of the time you can have a 4 milligram one. Then we have the IV or intramuscular, intravenous, or subcutaneous. Those are less favored these days because the intranasal one are very easy to administer. You administer every 3 to 5 minutes. You may have to keep repeating and repeating multiple times. In the past, they've said, if you have given up to 10 milligrams of Narcan without any response, start thinking of other things. But in the age of fentanyl, what you hear from EMTs is that, sometimes they need to administer so many ampoules of this before the patient comes around. So it's a different day. When patients overdose on long-acting opioids like methadone, it's best to keep them on an infusion of Narcan, because the methadone has a very long half-life. It's about 24 to 36 hours half-life for methadone. The Narcan only lasts about 30 to 60 minutes. So if somebody wakes up, it doesn't mean they're up there ready to go. They might go back into coma like 2 hours later because the effect of the Narcan wears off and the methadone is still in the body. So they need to be kept on an infusion or continued treatment for at least 24, 48 hours prior to being discharged from the hospital. And lastly, for buprenorphine, Narcan may not be difficult to displace, to work for patients who overdose on buprenorphine, because buprenorphine binds very tightly to opioid receptors and is very difficult to dislodge. You may need a very high dose of Narcan to dislodge it. The good news about that is the protection is that buprenorphine has something called a ceiling effect. It doesn't matter. Once you hit 32 milligrams of buprenorphine, you already occupy 98% of opioid receptors in the brain. So you don't get any extra additional therapeutic benefit, but you don't have any adverse effect as well, including respiratory depression. All right, so that is it. Thank you so much for listening.
Thank you so much, Dr. Ajabi. Now we'd like to open it up to a Q&A panel. We have Dr. Ajabi. I don't know if Kathleen, she may be leaving. Duty has called. She has a mom in labor, so she may or may not be with us. And then Lisa and Danielle, who you saw from the video. So we'd like to open up the chat to individuals that may have questions for our awesome panel.
Please start out with asking Kathleen a question while I still see her on here before her mom is ready to push the baby. Yes.
Yep.
Well, first of all, thank you for being with us. And Kathleen, do you have any feedback for our audience about what, treatment professionals or community health workers can do to better prepare a mom who might be on MAT to be ready for childbirth?
Yeah, thanks, Monica. The really important thing about this plan of safe care is educating people about it. The more I talk to people, healthcare professionals, social workers know about it. Healthcare providers are really not aware of it. It's a fairly simple document, but it requires the provider to really know their patient and share that information. It's been my experience that the information that we get as care providers isn't always well documented in the medical record, be it Sorian, Epic, or your own personal EMR. And most of the social workers will sit down with the patient, as Lisa did, but sometimes it's not that well done. And charting on the medical record, who are those patients, who is helping this mom? Are they reliable? Does she have a home? Does she have a safe place to go to? Does she have community support in labor? Who's taking care of the kids while she's in labor and delivery or postpartum? These are important things for a community worker or provider and everyone to be asking the mom to help her develop that plan of safe care. And then most importantly, documenting it in an area of the chart that's easily accessible to those in the hospital who need that information to develop the plan of safe care. I know when I'm working with moms, I really try to emphasize with them, this is not a threatening document. This is who's your safety net. That's really what this document is all about. And I think Lisa, just quickly, Lisa talked about planning for hospitalization. It's really important for all involved to check on that breast pump. That's so important to women. We want them to breastfeed. It does decrease the rates of neonatal abstinence syndrome. It increases bonding. It increases that sense that moms are the treatment for their babies. So really making an emphasis on early breastfeeding, getting the pump, which is reimbursed by all insurances at this point, and just those basic educational needs. Breastfeeding, Dr. Ajabi brought up contraception, so super important. Such a large percentage of these pregnancies are unplanned. So talking about contraception in terms of long-term, not the birth control pill, that's a 24-hour system. You want long-term methods, and these are easily accessible. Many websites, Planned Parenthood, lots about ACOG has great resources for anyone, or I can send you information on what's available to these moms. You want to simplify their life, make it easy for them to be compliant. And then the last thing I think I would address, and this is especially important for everyone in the plan of safe care, and Dr. Ajabi did bring it up, postpartum depression, that fourth trimester, after everyone has said and gone, the party balloons are deflated, the cake is gone, that mom is home with her baby. And sometimes postpartum depression is a significant barrier. we need to make sure we've got, that's that plan of safe care. Who's your safety net? Who's going to be checking in on you? Who's going to be making sure that you're okay? And if you're not, how are you going to communicate with myself as a care provider? So those are the really important pearls that I would emphasize right now.
Thank you, Kathleen. Any comment you have on, as you know, a lot of the moms are late care seekers for a number of reasons. Do you
Can I add something to that real quick?
Oh,
I just
sure,
wanted,
Danielle.
I wanted to say, Kathleen and Lisa, they both did the part to make sure that, like, I know that people make the plan with the hospital and make sure, all the ducks are in a row, but they both made sure that they had the plan that I was doing with the hospital so that I ran into no bumps there. Like, everything went so smoothly. They made sure they contacted everyone on what I was doing and everyone was up to date. So when I got to the hospital, it wasn't like no question about what I was doing. So I wanted to add that too. That was very easy and stress-free actually. So thank both of you for that.
Yeah. And Danielle, so that really goes into who really should do this plan of safe care. And right now it's really set up to be done postpartum, but that doesn't mean no information can be obtained until postpartum. This can all be laid out, and you as the active provider, the mom, you can be right up front and here's my plan, because it is your plan. And so you doing the antepartum is very helpful for everyone.
I'd like to add to that too as well, Kathleen, and thank you so much for your insights, Danielle, because who better to learn how to do this well than from the patients themselves, right? Aren't they the experts on how to best engage with them and collaborate with them? And thank you, Danielle, for your participation in all this, because, Plan of Safe Care is a wonderful opportunity for us to engage in partnership and collaboration with our patients early on. The earlier we do it, the more that this is all going to flow for them. Knowing that stress is one of the #1 vulnerabilities to relapse for our substance use disorder patients, we can eliminate a lot of that by doing this ahead of time. And I know Kathleen would add to this as well, but having that collaborative partnership based on kindness and compassion and respect and, genuinely valuing with unconditional positive regard the folks that we're serving really does make a difference in them engaging in care. We know that stigma and fear are a lot of the reasons people don't seek treatment, especially pregnant moms. And so the way that we treat them really has a lot to do with whether or not they're going to stay in treatment. They're going to come back for a second visit. Something good to keep in mind.
It really does. And really quick, Kathleen, you were great with me. I actually met you at a really rough time that I was having. And, the first thing I was expecting was I'm going to go in here and she's going to judge me and I'm going to be so uncomfortable. And you actually, you made me feel really comfortable and you made me want to come back to you. So I just wanted to thank you for that because, in the situation I was in, I had relapse and I was pregnant and I was using and I had to put myself in rehab. So I just felt shitty all around. And I think you realized that I already felt, bad enough that you're not here to help me feel bad. You're just here to help me better myself. And I wanted to thank you for that. That really meant a lot to me.
And I'll make sure that Kathleen knows that because she did just send me a message. She had to run. I guess the baby was coming. So,
Calls, yeah.
Yes. But Danielle, you obviously, as has already been mentioned, you are the expert in this. We have a number of different providers and on this call today, do you have any thoughts that you might want to share that can be passed along to other addiction treatment professionals, for instance, in terms of what can we do to help somebody in your position who is on an MAT, who's pregnant and is getting ready for childbirth? What kind of things worked for you?
I guess it really all starts with comfort. Like Lisa was saying, like the compassion and stuff, like nobody wants to go back to somebody who doesn't make you feel comfortable because of what you did in your past or what you're trying to overcome. Like, so with me, I was blessed to have a group of people that all made me feel like I wanted to go back. Not only that, when they make you feel comfortable, you feel that you can open up to them. You can tell them more. You can be honest with them. So that way, you're not hiding anything. So if anything pops up, they already know this had happened. So you know what I mean with that? So I guess the number one thing would be compassion, like to have compassion for the fact that we have went through a lot, and a lot of us are survivors, and we're just trying to get better. So that's the number one thing. And I guess the other thing would be not a lot of people know about it. To be honest with you, the only people that knew about it, like when I went to the hospital, I was mentioning the program and not everyone even knew about it. So like doing things like this would be also a great thing because it's making awareness of the program.
That's great. One of the things that the two of you, Lisa and Danielle, have mentioned to me is one of the things that you did as part of preparing for childbirth and dealing with stress, you developed some little tool. Can you talk a little bit about that? You know what I'm talking about, right?
I think I do. The cards.
Yes.
Lisa, you want to go ahead?
I'll start. One of the things that I think is so important for our patients is to not only have community resources, but to have internal resources. And so Danielle and I spent a lot of time working on different breathing techniques and self-affirmations and things that were comforting to her. And so Danielle and I identified them on some small blank playing cards. And I happened to ask Danielle about them the other day. The baby was born in September, and she had them in perfect condition in her wallet still. And I don't know if you want to tell the story, Danielle, about how they were helpful to you in childbirth.
Yeah, actually, I was going, my doula, I unfortunately didn't get to meet her until about a week or two before my delivery. So like, she really didn't know that much about me. And she was trying to comfort me, and I was doing the pushing, and I was like crying. I was trying to give up. Like, I can't do anymore. And she's like, I'm so sorry. Like, I don't know what can I comfort you with? And the only thing I could think of, I was like, get my wallet. There's cards in there. And they say in there what calms me down. So she got the cards out and she was reading them. So she was able to sit there and talk me through a lot of the exercises that me and Lisa did. So they actually ended up being like a very resourceful thing.
That's so awesome.
Yeah. If any of our participants have questions for our panelists, I mean, please unmute yourself, or if you're more comfortable putting the questions in the chat, please do so.
Danielle, just so you know, I don't know if you can see the chat.
Right here.
I don't know if you can see the chat, Danielle, but a lot of people are thanking you for sharing your experience today. So.
Oh, I didn't look. Thank you. I was actually really nervous to share with all of you guys, but I guess the one thing I really wanted everyone to understand is that you'll get so much further being, I guess, more compassionate for us instead of judgmental of where we came from. Like, a lot of us didn't plan in our life that we were going to be addicts. Like, that's not what we looked forward to doing in our life. So for a lot of people to have compassion for that instead of just like meanness towards it, it means a lot.
It's maybe a good time to give a little plug for the science around compassion. There's a really great book called Compassionomics, and it's actually science behind the fact that compassion actually increases outcomes and actually increases health outcomes. And I'll put it in the chat. It's phenomenal to see that being kind and caring actually does make a difference in people's lives.
I'm curious if any of our participants today have heard of Plan of Safe Care before today, or have actually developed one. Uh-oh, your little one. But we do have actually a question, so I'll start out with that. As an outpatient treatment provider, should a clinician assume that a Plan of Safe Care has been done and have their first action be to work with their client to request a copy, or should they initiate one independently and then share with medical providers? What I would say to that is, so if you're an addiction treatment provider, I would encourage your staff to start the development, because I really don't see the OB providers being able to do this to the extent that somebody who is an addiction treatment provider can do this in their session with a patient. I mean, first of all, I think we have a unique opportunity with somebody who is on MAT. We tend to work with them long-term. So we know them really well. They trust us. They have a really good relationship with us. So I think we are in a really good position to take a lead on that and then share the document with the permission, of course, of the patient, with their OB provider, and then potentially the birthing hospital as well. But I don't know if Lisa or Danielle have any additional thoughts on that.
I really appreciated the plan of safe care because it,
I didn't hear the end of it. I'm sorry. The baby, I actually have the baby and he's screaming. So I didn't hear the end of what you asked.
In terms of the plan of safe care, having an addiction treatment provider taking the lead in developing it versus maybe expecting the OB provider doing that, we were talking about, you know, for me, it makes sense that the treatment provider takes the lead with that.
I felt, I guess, because I was seeing Danielle so frequently and really had a good idea of what some of her needs were. I was a good person to start developing the plan with her. I collaborated with the OB office on some of the components that they were filling in. And I guess I feel that, you know, as a roadmap, it really helped me to see what things I needed to cover. And by starting it early, we were really able to cover all of the things on the plan of safe care. And I could take the time to do that. I'm not sure that at the hospital, they would be able to take that time after the fact. Doing it ahead of time really seemed to make sense to me.
Yeah.
Yes, thank you so much. I appreciate that.
I agree too. I think that, I don't know if I would have felt as comfortable with Kathleen doing it as you because of how frequently I do see you. I just feel that, that would be the smart thing, especially that this program is for women who are, on like substance recovery things, right? Also, or just substance. So they're seeing counselors anyway. Am I correct on that?
Mhm.
Like the women that are in this program, they see counselors already, correct?
Yes.
Yeah, so I would feel that just like the same with, I'm so glad that me and you did the plan of safe care instead of sitting down with a CPS worker who doesn't know anything about me. Do you know what I mean? Like, I think that is probably the best thing to do is have your counselor do it.
Yeah. Thank you. Do we have any other questions or comments anyone would like to share?
Well, if not, we can give everyone 10 minutes of their life back. Thank
Well,
you
I-
all so much for attending, and obviously a huge thank you to Danielle for sharing her experience with everyone. We will be sending along, I put it in the chat box, we will be sending an email that has a resource packet included. It had the copy of today's slides, a template plan of safe care, the brochure that Monica shared with everyone, and some infographics surrounding awesome statistics, yay, surrounding all of this. So please reach out to anyone if you have any further questions. Again, this was recorded, so in the next week or so, you can expect to see it up, at least on the Lerner website, if not Crouse somewhere. And you can always email me. So thank you all so much. I don't know.
Yeah,
Mona,
also, thank you. I couldn't type it in there. I was trying. For everyone that's saying thank you, that actually means a whole lot to me because I was so nervous to talk to you guys. So thank you, everyone.
you're the best, Danielle.
Thanks.
Thank you, Danielle.
Thank you, everyone.
Thank
All right.
you.
Have a great afternoon, everyone.